and welcome to Pharmacy's pharmacy teaching videos. These series of videos are focused on minor ailments, so common conditions treated with over-the-counter medications and advice, and today we'll be focusing on headache and migraine. Headache is a common minor ailment with 70% of the population having on average one headache per month and 80 to 90% having at least one headache per year. Often it's a physiological response to situations, but can be particularly troublesome for sufferers. Often it's recommended that patients keep a headache diary which records each episode of headache, precipitating factors or triggers, severity, duration, associated symptoms, how often analgesia is taken, and how effective it is, particularly if they get headaches frequently. In the majority of cases, headaches will be self-limiting, so they'll resolve themselves, or will respond to simple analgesics. However, accurate diagnosis is vital to ensure referral of those who need prompt intervention because it can be a symptom of more serious conditions. The most common types of headache are tension headache, which accounts for 80 to 90% of headaches seen in community pharmacy, migraine, which is about 10% of headaches seen in community pharmacy, cluster headache, and chronic headache, such as analgesic overuse headache. So looking into tension headache, as we mentioned, this is the most common type of headache. It's bilateral, which means it affects both sides of the head, and is often described as a dull, mild to moderate, generalized ache with a pressing or tightening sensation across the forehead, which is sometimes described as a tight band around the head. It can also be referred to as a muscle contraction headache, which gives an indication of how it comes about, so through possible pericranial muscle contraction. It can be triggered by emotional stresses such as psychological tension, stress, anxiety, or fatigue, or lifestyle factors such as missing meals, irregular sleep patterns, long periods of travel, or lack of physical activity. Tension headaches usually last between 30 minutes to 7 days. The International Headache Society guidelines state that infrequent tension-type headaches are those which have less than one episode per month, and frequent episodic or chronic tension-type headaches have episodes that occur more than once a month. Simple analgesics such as paracetamol or ibuprofen should be recommended for tension-type headaches, and they're equally favourable. NICE recommends that codeine-based preparations should be avoided as there is a lack of trial effectiveness. If analgesics are used for more than 2 days a week, there is a risk of medication overuse headache developing, which we'll cover in a little bit. You can also find info on the contraindications, cautions, and restrictions for sale of over-the-counter analgesics in our pain relief video. NICE also recommends considering a course of up to 10 sessions of acupuncture over 5 to 8 weeks for the prophylactic treatment of chronic tension-type headache. Also, massage, warm baths, relaxation, and stretching can help, as well as obviously avoiding triggering factors. Next is migraine, which is a recurrent headache disorder and is often described as a pulsating and throbbing headache. It may be present with or without aura, which may consist of visual disturbances such as flashing lights, sensory disturbances such as pins and needles or different tastes or smells, motor disturbances, or language alterations, and these are usually an indication that a migraine is on its way. However, only about a quarter of patients get an aura. Migraines are typically unilateral, so they cover one eye and one side of the head, and they're described as moderate to severe pain. They may be accompanied by any or all of the following symptoms, so nausea, vomiting, photophobia, which is a sensitivity to light, or phonophobia, which is a sensitivity to sound. Migraines usually tend to last between 4 to 72 hours, and they generally affect younger people. So 80% of sufferers have their first attack before the age of 30, whereas incidence is rare after 50 years. Possible trigger factors include bright or flickering lights, foods such as alcohol, caffeine, cheese, citrus fruits, chocolate, preservatives or additives, abrupt weather changes or extremes of weather, so if it's very hot or very cold, long distance travel, loud noise, missing meals, strenuous unaccustomed exercise, altered sleep pattern or fatigue, smoking, hormonal changes such as from menstruation or ovulation, and emotional stress such as from depression or anxiety. Intolerance to light or sound explains why sufferers tend to need to lie down in a quiet, darkened room, and normal activities such as walking up the stairs can worsen the headache, whereas sleep often relieves symptoms. Severe migraine attacks are classified by the World Health Organization as among the most disabling illnesses, comparable to dementia and active psychosis, so patients can really suffer when they get a migraine. There are 4 distinct stages to a migraine, although not everybody goes through all the stages. So there's the prodromal phase, and this is a pre-headache stage where patients may get changes in mood, energy levels, behaviour, appetite, and sometimes they get aches and pains. And this can last between several hours to days before an attack. Then they get the aura phase, which lasts between 15 minutes to an hour, and we've discussed the symptoms of that. Then we get the main phase, which is the headache. Finally, we get the postdromal phase, or resolution and recovery phase, where most attacks gradually fade, but the patient may get some exhaustion or weakness from the cycle. So this table is a comparison of tension headache against migraine, so feel free to pause this video to copy it down. Alternatively, I will post this table up on Instagram, so you can always save the post there. In terms of treatment of migraine, any patients with newly suspected migraine headaches should be referred to their GP. Prompt treatment at first signs of a migraine is important because gastric motility can be reduced during an attack, which can cause impaired absorption of oral analgesics. So it's essential that analgesics are taken at the first sign of an attack, and a soluble or effervescent preparation can aid absorption. However, bear in mind that effervescent preparations contain a large amount of sodium, so may not be suitable for hypertensive patients or those who should be restricting their sodium intake, so those who have heart failure, for example, or during pregnancy. Treatment should ideally be restricted to a maximum of 2 days per week to reduce the risk of developing medication overuse headache. We will be looking into migraine as a topic in itself when we cover the central nervous system, but in terms of an overview of over-the-counter products for the treatment of migraine, as we are looking at minor ailments here, according to NICE guidelines, patients should be offered treatment depending on the severity of their attacks, associated symptoms, contraindications, and comorbidities. So, offer simple analgesia such as ibuprofen, aspirin, or paracetamol, or offer a triptan, which is a 5-HT1 receptor agonist, alone or in combination with paracetamol or an NSAID. Oral sumatriptan is the first choice triptan for migraine. If the patient has aura, then triptan should be taken at the start of the headache and not at the start of the aura, unless the aura and headache start simultaneously. Consider offering an antiemetic, so over the counter this would be Bucostem or prochlorperazine, in addition to the other acute medication. Remember that over-the-counter Bucostem is only licensed for nausea and vomiting associated with migraine and not for any other type of nausea. It's a buccal tablet, so it works quickly when placed between the gum and the upper lip. According to NICE guidelines, codeine should be avoided in migraine as it is not proven to help migraine pain. It reduces gastric motility further and has an emetic action which can exacerbate existing problems. Even though some over-the-counter products for migraine such as Migraleave do contain codeine, but the official guidance from NICE is to avoid codeine. Looking into sumatriptan a little bit more, over-the-counter sumatriptan is indicated for the acute treatment of migraine attacks with or without aura in adults aged 18 to 65 years. It should only be used where there is a clear diagnosis of migraine and should not be used prophylactically. The dose of sumatriptan over the counter is one 50mg tablet as soon as symptoms of migraine appear. If the patient responds but symptoms persist, then they can take a second dose after 2 hours, but the second dose must not be taken if the first dose was ineffective. The maximum is 2 50mg tablets in 24 hours when it's over the counter. Higher doses are licensed, but that's when they're prescribed. Also bear in mind, sumatriptan is contraindicated in patients with ischemic heart disease, mild uncontrolled hypertension, moderate and severe hypertension, peripheral vascular disease, or those who have had a previous cerebrovascular accident, myocardial infarction, or TIA. It's also cautioned in patients with a history or risk factors for seizures. Moving on to cluster headache. Now, this is a type of headache that occurs in less than 1% of the population. The pain of a cluster headache starts quickly and without warning, so without the preliminary signs seen with a migraine, for example, and the pain is described as excruciating. It typically occurs in daily bouts of 6 to 12 weeks duration, so headaches can occur from 1 every other day to 8 times per day. The pain is always unilateral and usually focused behind one eye, and it often occurs at night and lasts between 15 minutes to 3 hours, but remember the patient can get multiple episodes in a day. It's also usually associated with at least one autonomic feature occurring on the same side as the pain, so this could be conjunctival redness, lacrimation, rhinorrhea, nasal blockage, or drooping of the eyelid. The intense pain is caused by dilation of blood vessels, which creates pressure on the trigeminal nerve. It must be referred to a GP, as analgesics will have very little effect, and the GP will then usually refer the patient to secondary care to be seen by a neurologist, who usually will recommend use of triptans to manage acute bouts of confirmed cluster headaches in those over 18 years, as per NICE guidelines. Next is chronic daily headache or medication overuse headache. Medication overuse is a relatively common cause of intractable headache. It's essentially headaches caused by a medication which is taken by patients to treat the headache or in anticipation of the headache occurring, and often these analgesics are used for more than 3 days per week. It can be caused by simple analgesia such as paracetamol or co-codamol, or by triptans, and can occur after a relatively short use of such medication. Common features are that it lasts for at least 4 hours on at least 15 days of the month. Usually this is from overuse of one of the following drugs for 3 months or more. So triptans, opioids, ergots or combination analgesic medications on 10 days per month or more, or paracetamol, aspirin or an NSAID either alone or in any combination on 15 days per month or more. The pain often appears to never go away and is described as a dull throb or ache. It can be accompanied by a dull ache in the neck and shoulders. It's often present and worse on waking, increases after physical exertion, and becomes worse on discontinuing the causative medication. However, the headache resolves or reverts to its previous pattern within 2 months after discontinuation of the overused medication. So the aim is to break the cycle and avoid analgesics even if the patient is in pain, in order to downregulate pain receptors and return patients to their original acute headache pattern. NICE advised to stop taking all overused acute headache medications for at least 1 month and to stop abruptly rather than gradually, and advised patients that headache symptoms are likely to get worse in the short term before they improve, and that there may be associated withdrawal symptoms including nausea, agitation and sleep disturbances. Symptoms typically settle within 7 days but may take up to 3 weeks to fully resolve. They may also require alternative therapies whilst in withdrawal from the analgesics, so this could be massage, acupuncture, any relaxation techniques in the meantime. Anyone suspected of suffering medication overuse headache should be referred to their GP. This type of headache is why it's so important to be vigilant if patients regularly present with headache and buy painkillers for them. And finally, other causes of headache. In sinusitis, increased mucus production leads to higher pressure within the sinus and can cause headache. The pain is usually unilateral behind and around the eye and is typically worse on bending forwards. The affected sinus also often feels tender to touch. Headache can also be caused by viral infections, so influenza for example, which can cause a symptom of headache. There can also be a symptom of throat or ear problems as well as tooth problems, and may be associated with dehydration or caffeine withdrawal. In terms of referral, so danger symptoms to watch out for, headaches may rarely be a symptom of more serious underlying diseases, such as meningitis, cerebral hemorrhage, raised intracranial pressure, tumours, or temporal arteritis. Urgent referral is required if the headache is associated with recent head trauma in the last 1 to 3 months, associated with neck stiffness, vomiting, altered level of consciousness, focal neurological symptoms such as severe photophobia or blackouts, as this may be meningitis or subarachnoid hemorrhage, which is bleeding around the brain. If the headache is severe and associated with fever or rash, or if it's of sudden onset and more severe than any previous headache, especially if there is what's called a sudden severe thunderclap headache, as this is a symptom of subarachnoid hemorrhage and requires immediate referral. Or if the patient has pyrexia associated with their headache, especially if it's in children or if there are no other signs of infection. Routine referral is required if the headache is suffered by children under 12 years old, especially if it's recurrent, or first time in patients over 50 years old. As we've covered, it should be referred if it's suspected analgesic abuse or cluster headache, as well as if the patient is unresponsive to analgesics or the headache has lasted longer than 2 weeks. So that's all for this video, which focuses on headache and migraine. It's quite a big topic as it covers a lot of different types of headache and their treatments, but hopefully you found this useful. As always, please make sure to like and subscribe to our YouTube channel, as well as following us on Facebook and Instagram, where you'll find quizzes and posts related to the topic. Thank you.